Mother Knows Death presents External Exams with Nicole Angemi.
On our first episode of Mother Knows Death, we talked about the death of Matthew Perry, and this week his autopsy report was released. And since he had such a big history of addiction, I thought it would be perfect to talk to my friend, Dr. Bruce. Hi, Dr. Bruce.
How are you? Good to be here.
Thanks so much for being here today. I first met Dr. Bruce doing his podcast, actually. I was on an episode of Weekly Infusion. That's when I first met you. And then you came to Philly and we went to the Mutter Museum together. That was fun.
That was great.
So let's tell them a little bit about your history. You have been an emergency room doctor for a majority of your career. And how did you get into addiction? How well, not addiction yourself, into the specialty of addiction? What was it that was intriguing about that?
I mean, that's a good statement. How to get into addiction medicine. Most people are either codependents or recovering. So I was in the codependent. I got some great codependency stories. But anyway, I did internal medicine training, residency, and took boards. And immediately during residency, this is back in the 80s, there were a lot of guys that were like gung-ho for excitement, moonlighting in emergency departments. So I was out in Riverside, San Bernardino County, and there were a group of us, we moonlight at Riverside County Hospital, ER. And then once I finished internal medicine, passed boards, and then some of the people at Loma said, hey, let's start an emergency medicine training program. And so it's like, back then, there weren't that many residencies. It was sort of a new area of specialization. So we started the residency program, and we had to pick an area that I teach. And I thought, well, drug overdose and toxicology, that's great, interesting stuff. So I went to some meetings at UCLA. This is about 1985. And the first lecture was, I don't know if they called it sex, drugs, and rock and roll, but it was a doctor in addiction medicine talking about youth culture and adolescent addiction. And I was like, blown away. It's like I came there to hear about boring not boring, but drug overdose and toxicology. And then this guy's talking about, at that time, the Grateful Dead was still touring, and they had the docs that went with the Grateful Dead. And, and then it really melded youth culture, music, all these interesting things together. So I went up at the end of the lecture. I said, what is this addiction medicine thing? And so I sort of started some training, and I got a position doing adolescent addiction medicine out in Redlands within a year, and did it alongside of emergency medicine along the way, and worked with some great people at USC adolescent medicine department, and met Dr. Drew. That's how I met him at K-Rock, and I was sort of his fill-in by virtue of keeping my mouth shut when he did Love Line for decades. And that's it. And it's still to this day. So I don't do emergency medicine anymore. I quit during COVID because I'm not a first responder hero. I wasn't a hero. I was a wimpy guy. But I'm doing a ton of, so I do addiction medicine for a large medical system. I'm still out in Redlands, Riverside. And a lot of what I do is around opiate addiction, use disorder, they call it, and chronic pain, or both. And use of buprenorphine or Suboxone Subutex, which sort of segueing back into the autopsy toxicology report on Matthew Perry. And coincidentally, ketamine is just coming to the, it's very popular for treatment-resistant depression and for chronic pain, and, looking at that whole receptor system and addiction, lots of exciting things happening. But since his report, I have a lot of chronic pain patients that are on buprenorphine, Suboxone, Subutex, Butrans for chronic pain, and they also get treatments with ketamine. And so some very, very concerned patients are like, oh my God, am I going to die? I'm getting my ketamine infusion. I'm on buprenorphine. And the answer, of course,
we'll get into that, because I actually have a lot of questions about that combination and if that's a common thing, but we'll get into that a little in a little bit. But first I wanted to get started with just the basics of addiction, because I don't really have anyone in my immediate family that that struggles with addiction, and including myself either. So I don't know it on a personal level. So I do have questions about it. I'm a parent. I know you're a parent too. And one of my biggest fears is like one of my kids is going to grow up and fall into one of these addictions. And I guess my first question for you about that is this something that could happen to anyone? I mean, Matthew Perry said that when he was 14, he started drinking alcohol, and by 18, he considered himself like a hardcore alcoholic. Is this something that could happen to anyone, or do you think that there's some kind of like predisposing factors that make a person more susceptible to addiction?
Yeah, certainly there's biology, right? So first, if your father or mother alcoholic or first degree relative, and then there are issues with exposure. So um, if somebody starts drinking when they're 14, if they have the availability of alcohol or drugs and they start using them, then then you stop the psychosocial development, you arrest that way, and it's a matter of it becoming something that's routinely done. So, I mean, adolescence is a great thing to talk about because if you have a very structured existence, if you're home every evening and your parents are aware of what you're doing and they know your friends' parents and keep track of you, and you don't have that exposure. But what it amounts to, there's junk science around brain scans, but if you look at they did a study where they took, and this I'm just sort of generalizing it, but say 20 young adult males, and they had a control group who had no first degree relatives that were alcoholic, and then a group whose fathers were alcoholic, and they were not yet regular drinkers. Got them all drunk, stuck them in a functional MRI. So we know the area of the brain that lights up with cocaine and heroin, the reward area in the midbrain, and in a statistically significant proportion, the sons of alcoholics had a lot more activity there. So I mean, it's sort of a gross representation of the biologic nature of it. But if I don't, you can both be sitting having a couple of beers at whatever age, and what do you ask the other guy? Well, what does it feel like to you? And so, one way is to look at what part of the brain, amount of dopamine released, serotonin, neurotransmitters, activity in the reward center. So we know that there's a different uh, there's a different reaction or activity from alcohol. So the 14-year-old like Matthew Perry, I don't know, and again, if there's childhood trauma, if there's sexual abuse, physical abuse, pre-adolescence, that's another risk. There's a bunch of these different risk factors. So there's no one addiction. There's no one addiction gene, but certainly the biology is there. And then if you figure, I've had patients that say the first time I got drunk as a teenager, I knew that's what it was just like I never felt normal until that point, and I immediately was off and going after whatever substance it is. So
Do you
that's
think?
and then go ahead. So that's a very roundabout way of partially answering your question, which
Well,
is,
my question is, especially talking about that particular study, do you think that there could be some aspect of it not being biology, but just nature, just being around a dad? You saw your dad drink their whole life, and maybe some sort of center lights up in your brain because it makes you think of like a positive um
oh,
experience
absolutely.
when you were a child or something.
Right. So, there's conditioning, and certainly that would, and then a dad that drinks with a certain effect, or is he a binge drinker and abusive intermittently, or is he a daily drinker and abusive every day, or neglectful? It's so complex, but we know and then again, what about, bonding the first couple of years, attachment theory? So these things all come into play, and there's no doubt separating them is difficult, but you're right. There's parental modeling, and then there's the genetics there, and then there's the exposure. Very complicated, right?
Do
So,
you feel as if any drugs? I mean, I sound like a commercial from the 80s when I was growing up, but do you feel that there's like gateway drugs, cigarettes, alcohol, or anything that starts a child, because you have children that eventually turn into one of these addicts, is there some kind of like predisposing thing that you might see prior to an addiction starting?
Well,
So
again, it's that mood altering effect. And obviously, anybody that gets cocaine or heroin or methamphetamine, and it depends how much, but I mean, you're going to get that immediate rush and the euphoria. And once that part of the brain, the lizard, I call it the lizard brain, recognizes that, then, is it going to be available the next week? Is it going to be a year later? Because adolescence is a time when there's no rehabilitation if you haven't habilitated, if you haven't had the normal development that occurs. So the exposure piece of it, again, is if a kid's, is there a gateway drug? I say whatever drugs. Like for me, I tried pot when I was 15. I hated it. It's like just, and it was not something I was going to get addicted to. But you get a kid with the biology where they get more, dopamine release, whatever it is that causes there's some euphoria there. That's going to be a gateway drug. So to me, it's at that age, if you start having reward and euphoria from something it's like if you just like what's the problem with smartphones? What's the problem with online gambling? It's that immediate dopamine rush, whether it's, and kids watching, what's the average age for a kid watches porn in North America? 8 years old.
Is that real?
Yeah.
Oh my
I
God.
believe that's right.
Oh
And
my
I'm sure,
God.
I'm sort of generalizing a lot of stuff, but the bottom line is the more immediate the response is to a stimulus where you get dopamine, whatever, dopamine, glutamate, release of, these pleasure neurotransmitters, and if a kid doesn't have, they haven't built up any defenses, they haven't learned to, fend for themselves in difficult situations, that growth, the process, the 3 stages of adolescence, early adolescence, mid, late, if they can't get through that, the earlier they start, that's sort of where your psychosocial development arrests. So it gets very complicated. It's like a dysfunctional home, a using parent, pre-adolescent abuse. I mean, a lot of therapists will say, well, what went on during your mother's pregnancy with you? Was there a lot of stress? Was there high cortisol? All kinds of ways of looking at it that put you at risk. So, but to me, what's the worst drug? It's the one that the kid starts using. In this day and age, I worry about poisoning, right? It's like fentanyl, carfentanil, sufentanil, whatever these things are out there. There's this whole other expanse of risk that comes from just being exposed one time and dying. So that's the, with my kids, they're a little older now, but even in their 20s, I say, look, one dose, you go to a party and somebody says, hey, try this pill or, pot. There's disagreement, that whether there's fentanyl in pot, but definitely in cocaine, definitely any pill you get, the Xanax, the Norcos, the Oxycontins, these people, that whether they're cartels or whoever's selling the drugs, they have pill presses that make identical pills to the pharmaceutical, but they throw fentanyl in there. So that's the one thing that I don't think we thought about as much prior to this whole fentanyl scourge is poisoning. And so how many kids, they go to a party and a friend says, hey, try this, it's like they're dead. Fentanyl is
Well, I think that's why I'm so scared, because I was that kid.
right.
Like I've done, I did all that stuff when I was a teenager and never, like my older daughter, she's just she listens. Like if you say, don't try drugs because you can get killed and stuff, she listened to that. But I was that kid that was like, that ain't gonna happen to me. That's what's scary, because you hear about this all the time on the news and stuff. And parents just so distraught, obviously, because their kid wasn't even doing drugs, really, just like trying something, and they just died taking it once. It's so scary.
Yeah, a friend of mine, his mom, she passed away. She was like 101, but there was a delay in putting her plaque up or something. So they were at wherever, the cemetery, the mortuary, and they were at the marketing person's desk or something, but she said they had some sort of a video, and it would show a picture for a few seconds and then the next one. And these are people that had passed away. And she's a nurse, and her sister was, had a substance issue. So she was very, curious about all these young people that she saw, and they were sitting there for half an hour. She said just constantly. And she said, it seems like a lot of these people you have that have come through here or buried here are young. And they said she said, it's just unbelievable how many young people come in with, drug fentanyl overdoses. So whatever, it's just, but I hate, pot. Pot is just, it's no longer pot. I mean, cannabis today is so potent, and there's so much disregard for it. And that's, so what's, it's different now than it was when especially, the 80s, things started to change when the cannabis, all these strains that are, and then the wax, 90% THC, it's just it's a different actor, and affects brain development. And
I had a situation with edible weed that I have never, and I've tried some things in my life when I was younger, and then I haven't done anything since the 90s and except weed. And I took an edible weed, too much of it, I guess, and I was like tripping, like I was on acid or something. It was insane. I thought that I was poisoned. It was the most surreal experience, and I'll never do it again. Obviously, scared the shit out of me.
Yeah, well, it's definitely a different scenario than what was it in John Lennon's Harmless Giggle that he talked about pot. It was like 0.5% THC, and you compare that to who knows how much THC is in somebody else. You just don't really know what you're getting. But I don't know.
Oh yeah, it was. I was like hallucinating. It was terrible. I didn't even
Right.
know
Well,
that weed could do that to you.
Yeah, it's technically a hallucinogen. Yeah, and it's one of those things when kids start doing that when they're 13 or 14. It's the future is not very bright if you're smoking if you're using that kind of pot every day, right? So
yeah, it's definitely can't be good for your brain. So you deal with all different kinds of addictions, but you specialize in the opioid addictions. How, as far as percentages of your patients go, is that the most frequently used drug that people tend to abuse nowadays?
Well, it's still in high school. It's still alcohol, cannabis, right? Pot and alcohol are still the most common. Cocaine's made a resurgence. Ketamine abuse, Special K. There's, it just depends on the age group, and you're getting so much more news-worthy stories about fentanyl. Again, the overdoses, the poisoning, but we see most in the hospital system we're seeing mostly adults. And the question I have, it's like, it seems like there's just much disregard for alcohol and cannabis products in teenagers. I know, a few decades ago, I was seeing a lot of kids coming in for alcohol and pot problems. And I don't know if they're graduating more rapidly to methamphetamine, cocaine, but I don't see the referrals in our large medical system. So I'm seeing tons of adults, and still, the older adults, a lot of alcohol, and a lot of opiate patients. See, part of it is retention and treatment. So there's an opiate called buprenorphine, Suboxone, Subutex, Zubsolv, various names for it. And it's used, you give it on a daily basis to alleviate craving. And those patients stay with you. So we see them every month, every 2 months for refills, and they're retained in the program. So, with other drugs, generally you get them into treatment, they start working a program, and you don't continue to follow them. So you build up a lot of the opiate patients. It's much longer term.
So a patient would come to you that was either addicted to pills or even heroin, and part of their treatment is for you to give them this drug that's is it to kind of like wean them down off of it?
So buprenorphine is an opiate, and it was discovered in the 60s and trial. It's semi-synthetic. It's derived from D-bane, which is part of something coming out of the poppy plant. And it was trialed in the 70s. It was released in like 79 or 80 over here for pain. It was another pain opiate. They didn't really know where opiates went in the central nervous system. They didn't discover the first opiate receptor until I think 1976. And then it was like, oh, this is how opiates work. They bind to this receptor. I think it was the mu receptor was the first one. And then in the 80s and 90s, much more understanding of different opiates worked more in different parts of the brain. And this one, buprenorphine, they noticed it had much less activity in the brain, midbrain, minimal binding in the respiratory center. All opiates, it's not really talked about much, but opiates suppress the immune system. They decrease the hypothalamic pituitary axis that makes like testosterone. They decrease testosterone. And those are big things, immune suppression, respiratory depression. And it turned out the buprenorphine had minimal, like as a sole agent, if you put an IV in my arm and gave me more than the maximum dose, I wouldn't stop breathing, which is crazy for an opiate. If you add alcohol or Valium or something, it's a different story. But it's basically it's much safer. So they said, if you have an opiate addict and they come into treatment, you could offer methadone, which is a potent opiate. They have to go to a clinic, take it every day to alleviate craving. They said, why don't we release this buprenorphine in a higher dose form? Practitioners in their office can dispense it. And ideally, you have the patient go to, NA, 12-step meetings. They have a therapist. You follow them the recommendation at first was you see them every 2 weeks and every 4 weeks. But it was to alleviate craving, and it didn't go to the reward center. So this has been out about 21 years. And it was very controversial at first because what people in the recovery field would say is buprenorphine, Suboxone, Subutex, Zubsolv. You're giving an opiate for an opiate. You're not really clean and sober. And there was a lot of argument. How can you tell me that if you're giving an opiate to someone, they're not getting high on it? But a lot of studies were done, and they determined the retention and treatment. There's huge difference in retention and treatment, and the overdose deaths. So basically, right now the standard of care is like 1 to 3 years on Suboxone or buprenorphine or more when the patient's carefully monitored. And that's so in addiction medicine, when you're treating opiate addiction, can you take this? It's a sublingual form. It's a film or a tablet you put under your tongue. And could you take that and inject it and get high? Well, you can get high injecting Benadryl. I've had patients that snorted Prozac. I mean, certainly it's an opiate, and if you misuse it, there are issues. But it really has revolutionized. And the reason is, again, I'm still totally behind. I tell my patients it's almost a requirement. You have to go to work a program. You need to address issues in therapy depending on the patient, but definitely 12-step is the foundation. But what this type of thing buprenorphine does is once somebody has an opiate addiction, then what we find is the midbrain, the part of the brain that tells you to breathe and tells you to eat when you're hungry, drink when you're thirsty, the emotional areas, the messages once you have programmed those areas to get the opiate, when they don't get them, when you stop, the message is up to the cortex. And you can look at brain activity on a functional MRI, and you can see when someone's in withdrawal, what's happening is there's a tremendous amount of nerve firing up to the cortex, basically, which is what withdrawal is. It's the anxiety. It's, besides the opiate withdrawal where you have diarrhea and vomiting and abdominal, so physical symptoms. But, when people say they don't have a choice, well, certainly everyone has a choice, but there's so much intense activity from, it's almost like when they've done studies looking at dopamine levels in people that are detoxing from methamphetamine, cocaine, and they've compared it to people that are starving or are super water deprived, and their dopamine levels are actually lower when they stop a run of methamphetamine or coke or opiates. So what is the drive to get water when you're water deprived, or food when you're food deprived? I mean, it sort of supersedes all other anything else you want to do. And that's the impetus or the stimulation from the midbrain up to the cortex, the executive function area. So it's not an excuse, but it's an explanation. When someone becomes addicted and they use larger and larger amounts, when they stop, they're almost like a decorticated animal. That executive function area is not making the choices. So that's the beauty of buprenorphine for me, is it allows the individual, it sort of shuts off that, lizard brain overdrive to get the substance. And the person needs to take steps to maintain sobriety. They need to work a program and replace the time and energy they're spending getting the substance and being loaded with other activities. But I think today it's pretty well accepted. Even in the 12-step community, it's much more accepted using buprenorphine for opiate addiction. So, and that's where, I didn't treat Matthew Perry, and you're not supposed to diagnose or be the doctor for people dead or alive. But, I've gotten calls from patients that are, they're on buprenorphine. They heard there was buprenorphine in the guy's forensics, and then the ketamine, and, I'm not sure what else was in there. But
well, you were saying that with withdrawal, there's physiological symptoms as well as you have these depression, anxiety, and things like that. So apparently he was given the ketamine treatments because he was having like severe anxiety. And is that something common that would be given to these types of patients, is additional ketamine treatments?
So ketamine it's not controversial. It's just, there's a feeling that it's, like for anxiety, my understanding and the way our medical organization does it, I mean, for treatment-resistant depression, when nothing else has worked, they've even been studies when somebody is suicidal, giving a ketamine infusion. And again, and then also for chronic pain patients, right? And there's the anxiety thing. I don't give ketamine. I do work a lot. The other thing I do, I work with pain patients that are on opiates, and their primary care wants them off or decrease, whatever. And there's buprenorphine, the Suboxone is a higher dose form. Buprenorphine sort of first line if somebody needs a daily opiate. So I think he was on it for pain and addiction, but using it for anxiety, I don't really understand that that's a bona fide indication. Treatment-resistant depression and chronic pain are pretty established. Certain kinds of chronic pain, but in his case, there's, first of all, the infusions that are given for pain and depression, and the amounts that were found in his, had nothing to do with, he had huge amounts in his system like a week after his last ketamine infusion. So those infusions are much lower dose. I think he had pulls in his stomach. There was abuse. So the problem with addicts, if you find that something seems to feel good and work at a low dose, then why not take 10 times more? That's sort of, the problem you get into. I don't know all the details there, but the use of ketamine, certainly I used to be a doctor at raves, and they'd have a tent, and specifically ketamine's much safer. It doesn't affect the respiratory drive that much. When you first give the injection, it can bump up your blood pressure. There are various issues, but as far as your breathing, it's not a respiratory depressant like things like opiates. But when you mix it with, even though, like I said, buprenorphine is an opiate, it's quite safe in terms of respiratory depression. But when you start, I think he had some benzos like Ativan or Klonopin in your system. When you mix these things together, and then his ketamine was a very high dose, then that's when you get into real problems. Whether he had coronary artery disease, when you use a lot of ketamine, you can spike the blood pressure, you can get an arrhythmia. I mean, ketamine's a great thing for setting bones. It's a short acting thing, but I know when in ER days, you'd have somebody on a cardiac monitor, an O2 sensor. You'd have, it was like a critical care bed they were in. And
so that's when you would give it, when, like, if someone came in with a broken bone and you were trying to put it, like something that you had to put them in an extreme amount of pain just to get them to not be paying attention.
Yeah, propofol, milk of amnesia, the white stuff, like those are much safer. And ketamine, the residency training program I was on in the 90s, I think we were the first. I was just part of the faculty group, but we were probably one of the first people to use it. It wasn't being used until the 90s, and we started using it for the first trial we did was for pediatric anesthesia in the emergency department, because it's the immersion phenomenon where adults get it, and when they're coming out of it, they have nightmares and they have to be sedated and stuff. Kids don't really have that so much. And basically there's some secretion issues initially. It's a very safe anesthetic. Okay. But the anesthetic dose is much higher. What you're using for depression and stuff like that, it's like, I don't know, 0.5 milligram per kilogram. And then for IV, and then for the dissociative state, you're up, I don't know, 2 to 4 milligrams per kilo. It's a much higher dose IV.
So when he was going to get infusions, obviously you weren't treating him, but if he was to get this like therapeutic low dose, would he feel high at all from that, or that it's so low you wouldn't really even notice?
No, it's mood altering. And I've talked to some patients like the way it feels. Others are very uncomfortable. They don't like the way it feels. They don't like the way it feels at all. And again, K-holing, it was sort of a rave alternative drug, with MDMA raves, and people would snort it, take it in pills. But those were usually much higher doses. And it's sort of like when you think of, PCP, like dissociative. So you don't feel connected to your body. You can do anything to the body and you don't feel it because it dissociates your brain from the body. So it's that kind of ketamine, PCP, very similar. But what I'm saying, yeah. And I have some very bright patients, and I have some very down the line into the road with chronic pain patients, and they have a lot of questions. And I have one that was considering amputation. He had a very sort of a rare CRPS, complex regional pain syndrome. And he's looking into everything possible. But, he's concerned with ketamine. He goes, I don't want to get, a lot of people say, I don't want to get addicted. And, if it feels good, am I going to want to do it more? There's the way it's given medically, it's certainly a possibility. And if someone has an addiction history, it's not something, you have to be very careful with it.
Yeah, that's what I was wondering. Like, why, if someone has such a strong, I mean, he had such a strong history of alcohol addiction and then the opioid abuse, that why would you give them a medication that's known to be abused? I guess that was one of my questions. But
I may be ignorant. I don't know. I really don't know why they were giving it. Was he in such a state with his depression that it was considered sort of a last resort? Was it for some chronic? I assume he had chronic pain issues. And yeah, I mean, it would be it would be something to take into consideration.
So his assistant said it was for depression and anxiety, but yeah, I mean, he had multiple surgeries because he had bowel obstruction from the chronic constipation from the opioid abuse. He had a back injury. Yeah, he had multiple surgical adhesions. He was probably in pain for sure. So, but that wasn't reported as to why he was taking it. But you also see this thing with celebrities and famous people, that they get this VIP treatment that normal patients don't get.
Yeah, absolutely.
Well, and I was wondering that too.
Right. There was a guy I knew that was hired to be with a certain very famous rock musician, and he would stay with the guy at the guy's place, and they have so much power and money. The guy would get, and this was back in the 90s, but these FedEx boxes would come with Demerol in them and stuff. And the guy eventually, died. But my friend was very high power intervention. He did interventions, and he worked with, Fortune 500 companies and, various behaviors, people on the board that developed drug or porn or gambling addictions, and but he couldn't do anything because this guy, the hangers on and the gophers, and it undermines their ability to get treatment or to stay sober. So
Do you think that because at the time of his death, people were in his life seemed to be a little bit shocked about it because it seems as if he had been sober for like 19 months. Do you think my question is why start a new drug instead of just going back to the one that you knew? Is it because of like shame and embarrassment to say, "Oh, I'm not sober anymore," or did he think maybe because he was allowed to get that treatment that it wasn't bad, he just was taking a little
right.
bit more?
I mean, it could be a number of things. He may have exactly considered himself to still be clean and sober. I'm doing it. It really helped my depression. I'm going to treat myself. I don't know. Was he getting high? Sounded like he was, he had quite a bit in his system. And look, ask anybody that struggled with an addiction and what was there, they talk about stinking thinking, right? It's like, how did you rationalize, was it just F it, I'm going to go get loaded, or maybe I can get loaded and nobody will know because it's ketamine and I'm already on it. I mean, who knows? And did he have a heart attack? I mean, was it an arrhythmia and he's, in the hot tub, you're in the hot tub and you're getting dehydrated. I mean, this is all the speculation. So
Yeah,
of
I mean,
course,
he had I don't know if you saw the report, but he had emphysema.
right.
I mean, pretty extensive emphysema. Smoked 2 packs of cigarettes a day, which, nobody ever wants to talk about how bad cigarettes are on the body, but there was that. And then he had, in his LAD, he had 50 to 70% focal occlusion,
Yeah.
which,
You've seen a bunch of those on autopsies,
yeah,
huh?
exactly. I mean, he didn't have any fibrosis in the heart, so it didn't look like he had a heart attack as the immediate cause of death, but he was going to have one soon, basically.
Right.
Um, but yeah, I think that he took the drugs and passed out, and then he had some signs that he drowned underwater, was taking some breaths underwater. So there was a little bit of, not a lot though. There was a little bit of pulmonary edema with some foam, and he had in the petrous bone some hemorrhage too. So they concluded that that was a contributing factor to his death.
Tell me about the petrous bone thing.
So you can see hemorrhage in that bone in drowning cases, but it's not like if you see it, that doesn't mean the person drowned, but that along with other gross findings could indicate that he drowned, but he didn't have, like, typically if a person just primarily drowned, you would see a lot of foam in the airway
Right.
because of their last breaths, but he was probably already, his respiratory rate was probably already so low when he went into the water. So that's why there wasn't that much of it. And obviously he had super high levels in his blood that you would see in a patient that was under anesthesia. So, and in his stomach contents as well, they found remnants of it. So, which means
Wow.
that he took it, shortly before his death, a high dose of it.
Right. And you get that sort of that adrenaline, blood pressure spike, and that's when you're going to get your arrhythmias, and you don't have to have a heart attack as that'll do you in really quickly too. So, but
Is
yeah,
ketamine treatment is that FDA approved right now for other than anesthesia, like these?
it's
It
off
just
label. It's off
Okay.
label approved. Yeah, for treatment resistant depression and pain.
It
I
just
think.
seems like it's like, how like Ozempic's in the news right now every day. It's like ketamine is. I think Christy Teigen said she did it, and one of the housewives or something. It's like all the rage now. All the celebrities are doing ketamine treatments.
Oh yeah, it's the ketamine clinics are doing a booming business. So that's the problem when somebody gets trendy. It's and people with addictions, again, you want a quick fix. And there's also talk about, well, it's just like the ayahuasca circles, and that can rapid opiate detox, where you go in and get an IV of Narcan and reverse it, and now you're not an addict anymore, or ayahuasca circles, and you get the super hallucinogenic experience. And generally these things occur biologically, genetically, over time, related to, it takes a long time. Well, it doesn't always take a long time to develop an addiction, but usually it's a complicated long-term process, and recovery is too. It's one day at a time, but it's, you just gotta, sit back and listen and accept that it's going to take a lot of restructuring of your life. It's very doable. Sobriety is, a lot of people fail and they'll relapse. I mean, this guy, what was he, in detox 60 times or something like that? So that's a little much.
Yeah, that was one of the questions I was going to ask you. Is there a point where someone, I hate to say this, but is there a point where someone's brain is like damaged beyond repair for them to ever kind of have a normal life after struggling with an addiction like this? I mean, there was a point where he said he was taking 55 pills a day, which is mind-blowing to me because I've taken one Percocet and like thrown up all night.
Right. But so again, I had a patient, and I know this is the case. He was taking over 100 Norcos a day, right? And
oh my God.
Because I saw the receipt. Now, he was ordering some on the internet. He was going to doctors, but he's still my patient. He's been on, he's an older guy. He's been on Suboxone for some years. He does have severe COPD, chronic pain, lumbar stenosis and lumbar radiculopathy, blah, blah, blah. So he's really got pain, and he's been stable. But if you gradually increase your Tylenol, the Tylenol in there is what's going to do you in. But if you gradually increase your Tylenol, and your liver has the ability to, produce more of the enzymes that metabolize it, eventually, though, the kidneys, you get to a certain, I know it's like how many kilograms of acetaminophen have gone through your kidneys, and then boom, they're done. But so it sounds crazy, but over time, people develop a tolerance, and there you go. So it's true. I mean, when everybody's had a Norco or a Tylenol with codeine, boy, I'll tell you what, that stuff can make you nauseous real quick. And but it's like patients I've had, they're drinking, a couple liters of vodka a day for years, and biology, it's not good for them, but that it occurs over time. It's gradual, and it's
when one of these patients that has the opioid addiction is used to getting high off of, let's say, Vicodin or Percocet, and then they go to you, and then they get this like Subutex drug, are you saying that they still kind of feel the high, but it doesn't give them that feeling that they need to increase it more and more, which would lead them to overdose? They still feel high, right?
No. So basically, you're supposed to be off of any opiate for at least 24 hours when you start buprenorphine, Suboxone, subject. Why is that? Because even though it doesn't, people say, well, it's a partial stimulator, a partial agonist. It just works differently attaching to the opiate receptor. So, but it like has the most attraction of any opiate. So if I've been taking 4 or 10 Norco a day, whatever, and I put some Suboxone Subutex under my tongue, it's going to displace all the Percocet or oxycodone or hydrocodone. And even though you're attaching to the receptor, the opioid receptor, it stimulates it differently. So your body perceives it as withdrawal, and you get super sick. They call it precipitated withdrawal. And the other situation, if you stop somebody's opiates for 24 hours, they're going to be in withdrawal, and then you give them the buprenorphine, the Subutex, Suboxone, whatever. And within minutes, their withdrawal abates. So it's sort of, it's not intuitive at explaining it. It's like, so it's a partial agonist, or is it a block? It's a blocker. Well, it attaches to the receptor, but it starts withdrawal, but you can treat withdrawal. You know what I'm saying? It can be a little confusing, but it's, it's an opiate. It has a high affinity for the receptor, so it'll displace any other opiate. And when it does so, then your body feels like it's in withdrawal, even though it's it's attaching. But if you wait for somebody to be in withdrawal and you give it to them, it will resolve the withdrawal within minutes. So
Now, what if like a
getting high, one,
normal sorry, go
the
ahead.
last thing. So I said people can inject it. Okay. Like I said, when you start injecting things, it's not like taking it properly. So I've heard all the arguments against, oh, it's an opiate. You're not sober. You're not clean when you're using. But if you take it properly, now they say 1 to 2% of people will say, oh, it makes me relaxed or gives me energy. So those are people that you probably don't want to use Suboxone or buprenorphine in recovery. So it's one of those things. It's just like some people will take, I mean, it's not a great analogy, but some people will say, yeah, I took Motrin and I got a mood altering effect. So a variety of things can give you a mood altering effect, and some people get very attached to it. But it's very rare. It's very rare that, buprenorphine. I've had patients take double, they try to get high on it. They'll take the maximum 32 milligrams a day. They'll get the prescription, take 64 milligrams a day. And I mean, I've had that happen, and you can't give them an early refill, and they come in and I say, well, so what did you feel? Well, it didn't work. I didn't get high. It was a waste of time and I'll never do it again, whatever. So it's again, the binding characters. We're in the ventral tegmental area, whatever the midbrain reward areas, it has very little activity there.
So if a person like myself took that drug, what would I feel anything or?
You probably, well, okay, it is an opiate. So if you're opiate naive, and it depends on the dose you took, it's just like if you injected it, I said, if I injected into myself, would it stop my breathing? No. If it was a sole agent. Now, if I had a few beers, you inject the dose. But if you took 8 milligrams, I mean, we start somebody that's in withdrawal, we'll give them 4 milligrams under the tongue. And if I just did that right now, I probably initially I'd get euphoric. Okay. I've had patients tell me that were big pot smokers. They had a bunch of THC in their system. They came in for induction and afterwards to say, doc, that stuff, I did get when I had when I was using pot. And again, you have patients that you get them off the fentanyl and you're working with them and you drug test them and it comes back for THC. You don't want patients we're sort of harm reduction. That's my philosophy. I mean, I don't want them smoking pot, but I've had patients tell me if I'm smoking some potent pot and I'm taking Suboxone, I do get a buzz, and that's not good. So, but it's just in and of itself, 98% of people do not get a mood altering effect when taken within the dosage range that's approved. So
Now, does this drug help with pain?
Oh yeah. Yeah.
So my obvious question is then, if this is safer, why isn't this drug
that is a great question. And so here's what happens now. The pain physiology and the pain fibers and pathways and different types of pain are really, really much better understood now than they were even 5-10 years ago, right? And a lot of complexities there. It turns out buprenorphine, if you have pain in your foot or your back or your hand, the fibers go to your spinal cord. The dorsal, the back of your spinal cord has transmission nerve centers and sends the signal up. So buprenorphine blocks pain more in the spinal cord, right? Not so much up in the brain, sort of a crude way of explaining it. And that's doesn't have as much activity, the respiratory center. But so currently, according to the medical literature, if someone needs a daily opiate chronically for bona fide pain, whether or not they have an addiction history, then the first line medication is buprenorphine. Why isn't that done? I was talking to somebody today. I've talked to people at other academic centers. I was talking to somebody at an Ivy League program back east today for about an hour, and we share the same frustration. If it's first line, first of all, safety first, Hippocratic oath, right? So I've been pain medicine in my facility, large organization, on Wednesday and Thursday. I'm not a pain doctor. I just get referred. Pain doctors say, hey, can you see, Mr. Smith? He's been on 100 milligrams of morphine and 40 of Norco for 20 years, and we've tapered them. Now the pain's unbearable, or, we need to detox this for whatever it is. I just get patients that are already on opiates, and is buprenorphine a safer opiate? Yes. So what the literature says, we're not for starting people on opiates for chronic pain. Not a good medication for chronic pain, right? But if someone's already on it, it's like, why not? If it's safer, why not at least try to switch them and then either taper them off the buprenorphine, or, if they do need a chronic opiate, use buprenorphine. But there's a lot of pain specialists that are now I'm not a board certified pain specialist, so I get into it with some of these guys. One of the reasons is because what's the first thing, if you say buprenorphine, people, I don't know what that is, but the average person has heard of Suboxone, right? Subutex. They'll go, well, it's an opiate for addicts, right? Well, it's buprenorphine. That's the opiate. Well, an opiate's an opiate, and that's for addicts. And if you're giving that to pain patients, then, you're a quack. I mean, I've gotten called it. I've got probably 150 patients that I'm with the pain physicians. I'm not going out recruiting people. I don't start it. In rare cases, there's a low dose Butrans patch. If the primary care or pain physician says, I think this patient does need an opiate, then, I will work with them, but I'm not out there starting pain patients on it. But anybody that's listening to this, if you are on it, if you're on Norco, you're on morphine, it's just, if there's a dangerous, or there's like I use the example, if I talk to doctors, they say, if you have a patient on amiodarone, it's a great medication, cardiac medication for certain arrhythmias, but it is rough to manage, sort of toxic, not toxic, but so what I tell them, if a safer antiarrhythmic came out, and it was documented, just the physiology of it, the pharmacology of it, it's safer, does the same thing. And 5 years from now, you still had them on amiodarone. What would your defense be? There's no defense. So what I tell
it's
pain
just like a
physicians,
stigma of the drug, basically.
Exactly. So, right. And so I was talking to somebody at one of these university programs, because I was in fear of losing my job, because they said, you're an addiction medicine doctor. Why do you have 40 people on this for chronic pain? And I said, well, they were sent to me. They were on morphine, fentanyl, whatever. And they told me to detox them. Well, and when this stuff came out in the higher dose form of Suboxone about 2002, a lot of us got, and it wasn't just me, obviously. It was a lot of anybody that did addiction medicine and worked in a medical system. I work with an integrated pain program. So we have psychiatry, addiction, clinical pharmacy, physical medicine, psychiatry, addiction. So they'll say, you're the one, we don't want this patient on the opiates. Can you tape or detox them? But a lot of the patients would say to me, to other doctors working in pain clinics, hey, that buprenorphine stuff worked great for my pain. I could think straight. I could function again. And I didn't feel like I was taking anything. So when you switch people about, there's a great article in the doc is, published a lot. He says a third of people on chronic opiates that need to be on or felt to need to be on something that's strong for pain. A third of them, it's life-changing to put them on the buprenorphine. A third, it's okay, may not be as well received. And a third, issues. It's an opiate, nausea, dizziness, you're tired before it helps the pain. So, I'm a therapeutic nihilist. I think get the less meds, the better. But if you're going to, and again, I just work with pain physicians and we try and get people off the opiates. But if there's a lot of people committing suicide too, because 6-7 years ago, the CDC said get people at 90 or less MME, morphine milligram equivalent. So 1 milligram of oxycodone is like 1.5 of morphine. 1 of hydrocodone or Norco is like 1 of morphine. 1 of Dilaudid is like 4 of morphine. So you calculate what your equivalent in morphine milligrams is. And if they're over 90, got to taper them. Well, what if they were, I had a lady who's on 140 milligrams of morphine for 20 years. She's 70 years old. And suddenly the doctor's like, I don't want to lose my license. I got to get you below 90. No talk about risk benefits. So in the literature, it says, look, definitely over 50 MME, 50 milligrams equivalent of morphine, the risk of respiratory depression is, there's a higher death rate. So you certainly not only want to get them below 90, but under 50. And opiates are not a great chronic pain medication. But in the interim, if they need to be on an opiate, or if they're on one and you want to get them off it, why not switch to something safer? So that's my argument. It's not for everybody, but you hit it on the head. But there's a stigma, and one Ivy League academician who I contacted because I was like, hey, I'm going to get fired for what I'm doing, but I think I'm doing the right thing. He said, I said, why is this? And this was probably 6-7 years ago. I was talking to this guy, and he said, well, look at the money that Big Pharma puts into buprenorphine. Where is it? It's like 99% for use for addiction. And he said, unfortunately, a lot of doctors get their information from drug detail people, or, you watch TV. Well, there's not much Suboxone being advertised on TV, but just the information out there disseminated to doctors. If they hear about buprenorphine, they're hearing about Suboxone. And I get referrals. Can you talk to Mr. Jones about Suboxone? And I'll go, no, I can talk to him about buprenorphine.
Yeah, so you just basically have to rebrand it. You need to contact them and say, like, let's call it something else. And
it's off-label FDA approved Suboxone Subutex for chronic pain, right? And the problem is, in this country, the higher dose forms are Suboxone Subutex. So, like Medicare, DHHS put out a sort of a pain management bulletin. I think it was 2017 or 18 or 2019 September. But basically, they had a flow diagram, and they said, well, and this is DHHS, and then the VA and Department of Defense in January. But basically, their guidelines were, if somebody needs to be on an opiate, try and get them off the opiate. Opiate's not great. It's really not good for chronic pain. But go with buprenorphine to either detox them, or if you choose to maintain them on an opiate. Medicare does not pay for the higher dose forms. So you have somebody that's 66 years old, you've gotten them off their fentanyl patch and their Norco, and then they go to fill the prescription, and the pharmacy goes, oh, you got Medicare Part D, you have to have an addiction diagnosis for us to pay for your Suboxone or Subutex.
Because they just want people to die so they don't have to pay for them anymore. That's my theory.
The government.
Yeah, it's a whole other episode, Bruce.
Yeah, get Kennedy on here. I'm sure that guy's got some
interesting.
You need a contrarian. You need a shit stirrer. But
yeah, I mean that would be fun actually to hear that. But I think that I mean I'm one of these people that are just like, there's the whole entire time you're talking about this, I'm like, there's absolutely no reason except these barriers of and it has to do with money being made, right? Like that's how I look at it.
Well, I'm telling you, I guarantee you, I don't know how many people you have listening when this thing airs or is dropped, but you will get just a shitload of that doctor doesn't know what he's talking about, or he's a shill for the drug companies. That's the worst. I have had, if you go to drugs.com, I mean, there's a billion pages, but there's one there that says buprenorphine should not be used for pain. It's a terrible pain drug. So when I get a referral, from the pain doctors, probably I'll have 3 or 4 tomorrow, let's say Tuesday, Wednesday. And I spent, and my organization's great. They give me an hour to talk to them, and then I will spend an hour, and I don't know what I'm getting. Some of them are fit to be tied. They've had their opiate tapered. Others are, I don't know who you are. I don't know what this medication you're talking to me about is. And I'm like, I don't know if I'm going to get, punched in the face or yelled at. But I say, well, they say, well, they said you're talking to me about Suboxone. And I'll say, I want your family. Anybody has your nose in your medical business, I'll talk to you about this medication. But I explain what I tried my best, like we were talking about today, how it's different, how it's better if you're not on any opiate, blah, blah, blah. And I've had family members, and then I won't prescribe it until a week later. I'll say, I want to meet with you again and the family, bring questions. And it's really a shame. There's so much misinformation, and, people that are suffering in pain. I'll tell you what, it's really one of the most underserved communities of patients in medicine. I mean, because it's so frustrating for doctors. What do you do with these people? You can't give them opiates. They have something called the Beers list, Beers. I think it was a Dr. Beers. It's got nothing to do with drinking beer. And it's been around since the 90s. The Beers list are medications you shouldn't give people over 65. Yeah, there's antibiotics on there. It's muscle relax, smooth muscle relaxants, opiates. It's really the hands of pain physicians are more and more tied. That's why things like ketamine infusions, you're able to do that. You're not sending them home with it. Well, in some cases they have, but that's available too. Anyway, I'm rambling.
No, this is really good information, because I think that a lot, even I just did a post on my website, The Gross Room, about Matthew Perry's death, like a more in just a dissection of the autopsy report. And a couple people had made comments under there that they are chronic pain patients, and they were taking hydrocodone every day. Like the one woman had said that she was taking 3 a day, and that kind of surprised me, because I think it's almost a perfect drug, that it could have the effect of the opioid but not make a person addicted to it, maybe, and high and able to function. I don't see why you wouldn't go with that.
Oh,
with this, like Subutex or so. Yeah.
Right.
It's interesting.
I don't know. Yeah. Yeah. I've had pain specialists say, well, they can only use it for pain if they have an addiction. They can only use it for pain if they don't have an addiction. It's just, well, okay.
It's really weird that they would want the patient to take the other one that could potentially give them addiction. You don't want to wait till a person gets the addiction. Maybe you want to prevent them from getting it.
The other one is kratom. You've heard of kratom, right?
No, I've never heard of that. What's that?
Kratom. We've been seeing that for years and years. So kratom is it's sold as a tea or a powder or a pill, and it's derived from a plant that's related to the coffee plant. And
okay.
It's sort of like tramadol. It binds the opioid receptor, the mu receptor, but it also has NSRI activity, norepinephrine, serotonin reuptake, like Effexor or Cymbalta. So, tramadol is an interesting opiate. And if you take too much tramadol, you have a seizure, right? Well, why is that? Well, it's because it's like, Effexor is a norepinephrine, serotonin reuptake inhibitor. So you take a bunch of Effexor and you get too much adrenaline in your brain, you have a seizure. So this kratom stuff, it's available in head shops in a variety of places. It's still legal, but it's mu receptor opiate. It has opiate activity and NSRI activity. So it's considered by a lot of people to be an herb. It's herbal, it's safe, and we're seeing more and more of it in terms of it. It's like an over-the-counter tramadol, basically. So,
oh my God.
That was, as far as the opiate.
And this is something you could just get at like a place that sells vitamins or something.
Unfortunately, yeah, you go to the places that sell the bongs and the vapes, and but it's an opiate. It's bad news. And then it's perceived as, it's sort of like, well, it's Eastern medicine. You doctors are prescribing all these other things, and it's not dangerous. But I've had, it's
opium.
I had a patient spending $15,000 a month for his kratom. You get tolerance, you get into major, and then when you stop, you get antidepressant withdrawal, right? Because it's got just as much activity as taking Effexor or Cymbalta, those kind of Pristique, the NSRI thing. So kratom, that's the other opiate that we're seeing.
I can't wait to look into that more. That's really interesting.
Yeah, KRATOM. Don't.
We're not trying to push it. We're trying to tell you not to do it. It's not good. All right. So to wrap this up, all right, go ahead.
So the last thing is, doing adolescent addiction medicine, they'd send you out. They used to send me out with this guy that was a character actor. And I remember they'd send us to all kinds of school. But I was reading all the prevention literature, and it turned out kids in especially middle school that got, when they they'd have the drug recognition cop come in or whatever, and they pass around the pod
The
or the
Dare
different.
t-shirts and everything.
Right. But when they pass around, like, this is what a joint looks like, they had this thing in a box and it said, here's a needle, here's a joint. So they found that when kids got information and they were essentially desensitized, and those lectures there versus not getting information, their drug usage would go up. It would put them more at risk because they were desensitized. It's like, oh, that's what a joint looks like. Oh, that's LSD looks like.
Yeah,
So
like you're
that's why
actually teaching them how to use drugs.
yeah, well, yeah, it's like their natural, any kind of fear they had was sort of dissolved, and they're like, oh, that doesn't look that dangerous. So
Yeah,
anyway,
right? Oh my
all
God.
right, well,
So if you had, my last question for you is, if you had like a magic wand and you've seen all of these people addicted to opioids, is there something, I mean, obviously we might have already talked about this, that we have this one drug that you don't think is being utilized as well as it should be, but is there anything else that's like blatantly obvious that's going on with either just the government's response or how we've gotten to this point that I feel like it's worse than anything I've ever seen? I mean, you're familiar with Philly. We have a
no,
huge problem here, like huge in Kensington, just street, and in Camden too, where my husband works. I go visit my husband at the firehouse, and there's just people lined on the street, standing up, nodding off, and it's just terrible. How
yeah.
how did we get to this point, and how do we go away from it?
Well, I mean, you can get into the politics of it, but the permissive, I was talking to there's no fundamental objective truth. It's like I was talking to somebody that was in some sort of social service thing, and I said, well, somebody's psychotic and they're running down the road naked, thinking that they're God. Wouldn't it be better if they were on medication and sort of put in some sort of mandatory? Well, maybe they're happier that way. It's like, wait a second. So the bottom line is homeless. Here's the simple solution: forced treatment of the addiction, or the recognition of the mental health addiction. That's what you got to treat. You give them needles, you give them a safe place, you give them drugs to use. That's insane. That's effing insane. So we know what it takes. We know what's the problem with these people. That it's not capitalism. I saw some moron from San Francisco. It's capitalism. They're freaking addicts. They have a drug addiction. Ask any addict. The only thing that saves them: drug court, getting locked up. You're decorticated. It's like when you have those frogs and you pit them and they still move around. That's what these guys are. Once you're addicted, especially meth, high potency stuff, meth and coke and opiates, they can't choose. And then you put them and they're out on the street. They're all tri-diagnosed. I mean, there's psychiatric issues. They have health issues by that point. I mean, physical issues, but psychiatric addiction, you have to step in and mandate or give them a chance where they can, So anyway, that's the bottom line with homelessness. And I don't know why, these arguments that it's inequities and financial things. 90% of these people have psychiatric and or addiction and or psychiatric. And, you can give them all the money in the world, all the food. It cracks me up when they distribute turkeys at Thanksgiving to the homeless population. It's
Yeah,
great.
it is crazy. You're just like, you're missing the point, people.
And
I
I'm
mean,
seeing it through my
it
white
feels
filter.
good in the moment, Yeah,
Yeah.
exactly.
Yeah. No, I mean, you have to have compassion. But if you know that if you stick their head in a brain scanner, which you can't reduce everybody down to a lab animal, but once they've been that intense in stimulation of their reward center, drug, they can't, it's like somebody that's starving and there's food there. Are they going to put clothes on or eat the food? Are they going to, what I'm saying? It becomes it's an existential thing, right? They talk about existential crisis. Like, they got to get the drug. They can't make the choice themselves. And so homeless population, if I had a magic wand, you'd get these people the help they really need. And and mandated. So,
You know,
okay.
it's interesting. You have like a really different, because like right now, I just went outside to go get my mail and it feels like it's about to snow. It's freezing outside here in Philadelphia area. And you guys have like this beautiful weather all the time. Michelle told us it was like 70 and sunny and out. And you have people that are flocking to live there, a huge homeless population. We do too here, but not anything like what you guys have. It's just different here. But I don't know if you've seen, there was this one, I don't know if it was a YouTube or Instagram account that was called Kensington Beach, and it was this guy that was just going and filming all of these people. It looks like the zombie apocalypse. It is just,
Right.
it's insane what's going on in Philadelphia area right now. And I don't necessarily think that it's a huge homeless situation. I mean, there's definitely a lot of it, but not anything like we're seeing in California. But the the drugs, I mean, there's people there that have necrotic legs, wounds, open wounds with maggots on them, just on the street, nodding off. It's just absolutely insane what's going on there.
Right. It's like, where does compassion, what is real compassion for someone? Sometimes,
Yeah, and
helping
giving
them.
them clean needles is not helping them. Like, I mean, obviously, like it's just not helping them. You could say
No.
that.
And
It's
yeah, and certainly maybe they were victims of the system at one point, but um, yeah, you just talk to people that have been homeless and then got sobriety and got mental health care. They're not going to be endorsing safe injection places and providing shelter. Let them live in, here's a place they can sleep, but you're not treating their addiction or their mental health issue. You're really just, you're contributing to their demise. I
yeah,
don't
and
I
who
don't know how
cares
to,
if
but it's
I mean,
also
who cares if they're using clean needles though? Because if they're never going to have a quality of life, like what's the difference if they get HIV? Really, think about that. If they're just going to be living like zombies on the street, who cares if they get infectious diseases if they're never going to have a good quality of life? I mean, that the
yeah, well,
ultimate goal should be for them to have a good quality of life.
yeah, well, pathologists are seeing stuff they haven't seen in 100 years, right? A lot of
Oh yeah, I'm hearing some
stuff
crazy
that's
stuff.
yeah, well, it didn't. The system caught things early enough, but these people, the diseases are. It's sort of like a fourth world nation where things just there's no intervention for it.
Yeah, it's incredibly sad. Well,
Lunatics
thanks
ranks.
so much for being here with us today. This was great. It's very informative because this is so outside of my normal realm of knowledge, and you taught us a lot. It was really good.
Oh, well, great. Any bad feedback you get about me, please don't tell me. I'm very sensitive to criticism.
All right,
I want
Bruce,
to
I'll talk to you later.